All right, so today we're going to talk about diseases of the thoracic aorta. So starting with the anatomy of the thoracic aorta. So we have the aortic valve right there at the bottom at the junction with the left ventricle. And then we have the sinuses of Valsalva above that. And then above that we have the sinotubular junction. So that's the area where the aorta just starts to narrow a little bit. And above the sinotubular junction, we have the ascending aorta. So that's the part of the aorta before we get to the great vessels. Then we have the proximal aortic arch. So the aortic arch is the part of the aorta where the great vessels come off. So we have proximal and distal aortic arch. So the isthmus is that part of the aorta just distal to the left subclavian artery, just before the insertion of the ligamentum arteriosum, and then after that we have the descending thoracic aorta. So that's the basic anatomy of the thoracic aorta. So here it is on angiography, where you have these outpouchings, those are the sinuses of Valsalva. Then we have the ascending aorta from there to the brachiocephalic artery. The sinotubular junction is the area that just starts to narrow right above the sinuses of Valsalva. And then we have the aortic arch where the great vessels come off, and the isthmus is between the left subclavian artery and the insertion of the ligamentum arteriosum, descending thoracic aorta after that. So we'll start by talking about the acute aortic syndrome. So these are what the acute aortic syndromes are. The patients usually present clinically the same way. They usually present with chest pain radiating to the back, and usually, the ER wants to rule out aortic dissection when patients present in that fashion. So we start with a chest radiograph, and obviously we can see that the aorta, thoracic aorta, is markedly enlarged, so we suspect an aortic aneurysm. And here we have a nice big aortic aneurysm there. Let's see, is there a way to move this? Get that out of the way. Now the problem with aortic aneurysms is as the aorta starts to enlarge, because of the law of Laplace, you start to develop more tension on the aortic wall. So that leads to progressive dilatation of the aorta. So the natural history for aortic aneurysms is once they get to a certain size is for them to continue to enlarge. There's been a recent change in the definition of what we call an aneurysm. So an aneurysm of the ascending aorta now is defined as greater than or equal to 4.5 centimeters in diameter. If it's between 4 and 4.4 centimeters, then we can refer to it as dilated. But once we get to 4.5, we can call it an aneurysm. There's very high risk of rupture once it gets to 5 centimeters and greater. If you're dealing with congenital syndromes like Marfan's, then 4.5 centimeters is the number where the risk of rupture goes up. For the descending aorta, the aneurysm greater than 3 centimeters. A true aneurysm contains all layers of the aortic wall. A pseudoaneurysm, there is no intima within the wall of the aneurysm. So aneurysms can be described as fusiform, where we have symmetric radial dilatation of the aorta, or saccular, where you have an outpouching from the aorta on one side. So when we see a saccular aneurysm, you might also suspect the mycotic aneurysms, as mycotic aneurysms tend to be saccular. And as we've said, once the aorta enlarges more than 5 centimeters, especially when it gets to 6 centimeters, you really have a significant increase in the risk for rupture. On chest X-ray, we would suspect an aneurysm whenever we have a mass that we cannot separate from the aorta itself. So if we see that, then we would obviously suspect an aneurysm, and easy diagnosis there on CT. And with these large aneurysms, it's not unusual to have large areas of thrombus that build up within the aneurysm. So we can get mural thrombus, you can get calcification in the aortic wall or within the thrombus itself. So we can get that, and if you start to see anything that looks like soft tissue or hematoma outside of the aneurysm, then we need to suspect rupture. As in this case, it looks like there's some hematoma extending outside the aorta itself. On a non-contrast CT, if we have high attenuation crescent, that could be a sign of imminent rupture. So if we see that, then we can suspect imminent rupture if you see high attenuation crescent like that. Here again, also another example where we have some crescent, but there's also hematoma there outside of the aorta. So that means that we have rupture in that case, if we see that. Okay, you guys over here, do we have anything to say about this case? What are the findings? What do we have to say? Yeah, so one or all?
At least two.
Yeah, at least two, probably all three, right? So we have some enlargement here, and what about the aorta above that? Yeah, so it's okay, although it's a little bit bigger than the descending aorta there. So what would do this? What would give you an appearance like that? Yeah, sure. So Marfan's, and then the other term for that when we have dilatation of the ascending aorta that extends down to the aortic root, we call that, the sign is the tulip bulb sign, right? But we call it annulo-aortic ectasia, all right? So here's so in that particular patient, it's a very nice tulip bulb sign here from dilatation here of the ascending aorta extending down to the sinuses of Valsalva, nice tulip bulb sign. So this, of course, is associated with Marfan's. So annulo-aortic ectasia, cystic medial necrosis causes progressive dilatation of the aorta extending down to the aortic annulus and proximal aorta, complications, dissection, aortic regurg, rupture. So here's the sinotubular junction there, and then with annulo-aortic ectasia, you get dilatation of all of the sinuses of Valsalva, as opposed to just one sinus of Valsalva. So this can be associated with Marfan's and Ehlers-Danlos syndrome. So we'll have dilatation of the aorta extending down to the aortic root, and another complication of this is also aortic regurgitation. So whenever we get dilatation of the ascending aorta, especially if it involves the aortic annulus, the valves cannot completely close, the aortic valve cannot completely close, and so then you can have aortic valvular regurgitation. So that's a complication of annulo-aortic ectasia. So here's some more examples here. You have dilatation here going down to the sinuses of Valsalva, another example, very nice example. And then here there's also dilatation of the ascending aorta above the sinus of Valsalva. So these are examples of annulo-aortic ectasia, and nice tulip bulb sign there. Okay. The differential for aneurysms of the ascending aorta, of course, annulo-aortic ectasia can be Marfan's or Ehlers-Danlos. Aortitis, vasculitis can give you aneurysms of the ascending aorta, like Takayasu's disease. Syphilis, we don't see that much anymore, but that can also give you aneurysms of the ascending aorta, and trauma, including prior surgery. So that can also result in an aneurysm, or really a pseudoaneurysm of the ascending aorta. Okay, over at St. Barnabas, what do we think of this case? So what do we call that? Well, that's a sinus of Valsalva aneurysm, right? So here we have a sinus of Valsalva aneurysm, okay? So the sinuses of Valsalva, we talked about these guys. So these are the sinuses of Valsalva. So you have the cusps of the aortic valve. There's the non-coronary cusp, and the landmark for that is going to be the intraatrial septum. Then you have the right cusp, and then you have the left cusp. And so that dilatation of the aorta right above the aortic valve, those are the sinuses of Valsalva. So they allow the aortic valve to open in systole without striking the aortic wall. So here you can see the aortic valve in systole. You see it allows some space for the aorta so it doesn't damage the aortic wall. or obstruct the coronary sinuses. And it's also said that the flow currents here within the sinuses of Valsalva during diastole promote closure of the aortic valve. So that seems to be the function of the sinuses of Valsalva there. Okay? So we can have sinus of Valsalva aneurysms. Most involve the right sinus of Valsalva. Non-coronary sinus involved in a small percentage, and the left sinus is very rare. To have an isolated aneurysm of the left sinus of Valsalva is extremely rare. Okay? So sinus of Valsalva aneurysm, when we have enlargement there, usually congenital aneurysms give you enlargement of a single cusp. We saw some cases of annuloaortic ectasia where that can involve enlargement of all the cusps. Acquired sinus Valsalva aneurysms, usually they affect a single cusp of the sinus of Valsalva. So for the congenital aneurysms of sinus of Valsalva that might affect a single cusp, this could be from localized deficiency of the tissues there, of the aortic annulus, can involve the posterior non-coronary cusp, usually less than 4 centimeters, and these can also be associated with ventricular septal defects. So the ventricular septal defects can result in prolapse of the sinus of Valsalva downward, and that can actually close the VSD, but can also result in regurgitation, aortic valvular regurgitation. So the most common cause of sinus Valsalva aneurysm is congenital from localized deficiency. There's an example there where it involves the right sinus. We've said these can be associated with ventricular septal defects, and what happens with these high ventricular septal defects is that you can get prolapse of the sinus of Valsalva down into the defect, and that results in enlargement, so you get a sinus of Valsalva aneurysm. That can actually help to close the defect, but it also can result in aortic valvular regurgitation as a complication of that. So these congenital sinus Valsalva aneurysms can be associated with ventricular septal defects. Now, we've talked about Marfan's and Ehlers-Danlos, which can also give you sinus Valsalva aneurysms, although usually with sinus Valsalva aneurysms there, it involves all of the sinuses, and that's why we get this tulip bulb sign when we have all of the sinuses involved with dilatation. And then they can also be from, we can also get these from infection, aortic root abscesses, syphilitic aortitis, TB, might also result as a complication of dissection, trauma, or vasculitis. So that might also give you acquired, those are acquired causes of aneurysms of the sinus of Valsalva. So you guys over here, here's an aneurysm. Which sinus is that?
Right.
Yeah, so that's the right. You can see the right coronary artery coming off here. So there's a right sinus of Valsalva aneurysm here. Note its relationship there to the right ventricle. Okay. Over at St. Barnabas, which sinus is involved here? Yeah, so this is an aneurysm of the left sinus of Valsalva. So these are actually extremely rare. Notice the relationship of this, though, to the left atrium, especially the left atrial appendage. Look how close that is to the left atrial appendage. Okay? All right. So you guys over here, what do you have to say about this case? What kind of view is this? What kind of study, what kind of view? Well, you should be able to tell me what kind of study this is. Bright blood, SSFP, what view is this? Yeah, it's an outflow tract view, so this guy is left atrium, left ventricle, aorta. What do you think of the size of the chambers? So what's dilated? What chamber is dilated? The left ventricle, right. So here's the left ventricle. We can see the left ventricle is dilated. So can we diagnose what the problem is? What's causing the left ventricular dilatation here? There is aortic valve regurg, right? You see the aortic regurg there. So what's the cause of the aortic regurg? Well, the cusps aren't coming together completely, right? That's the cause of the regurg, but why? There's a big sinus of Valsalva aneurysm right there. See it? All right, so there's a sinus of Valsalva aneurysm here that's resulting in this complication of aortic valvular regurgitation. And that's why the left ventricle is dilated. Okay, so nice example of sinus of Valsalva aneurysm with the complication of aortic valve regurgitation. So, is there anybody here from Beth Israel? No? St. Barnabas? What do you have to say about this case? So, yeah, it's kind of what it says right here, right? There's a sinus of Valsalva aneurysm on the right side, but why else am I showing you this? You guys see anything? So the catheter is where? In the ascending aorta. We're injecting contrast, right? So we see some dilatation here of that right sinus of Valsalva over here, but is there anything else funny looking? Yeah, well, not to the right corner, but there's contrast that's coming downward here, right? So it's going down into a right-sided chamber. It's more than regurg, so what does that mean? So when you see contrast going down into the right atrium there, rupture, right? So that's another complication of sinus of Valsalva aneurysm, is rupture. So with these, we talked about aortic regurgitation as a complication, but rupture can also occur. Most rupture and it will result in aortic regurgitation and left to right shunt. But since a lot of these come off the right cusp, rupture into the right ventricle, the posterior cusp tends to rupture into or non-coronary cusp tends to rupture into the right atrium. So rupture into the right-sided chambers is most common with these sinus of Valsalva aneurysms just because of their location. So the posterior and the right cusps will rupture into the right-sided chambers. So the left, which is the rarest of these sinus of Valsalva aneurysms, they tend to rupture into the left atrial appendage because of the proximity. Okay? So ruptured sinus of Valsalva aneurysm, most will rupture into right-sided chambers because of their location. And so this is another complication of sinus of Valsalva aneurysm. Okay, so you guys over here, do we have anything to say about this case? Well, why? So why? What makes you think dissection here? Yeah, so here you have a calcification. Here's the wall, right? So here's a calcification, and actually look really hard. It does look like there's a flap here, okay? Even on this non-contrast CT. So you have a displaced intimal calcification. So a displaced intimal calcification can be a sign of aortic dissection. And this is a case of aortic dissection. So let's talk about dissections. We're kind of familiar with these. Separation of the media by a stream of blood, so it goes out into there, creating a false channel, and so we get this lumen, and this lumen out here with the false channels. You get a double lumen aorta, and the flap, which is what we look for to make the diagnosis of dissection. So the flap is composed of intima and an inner portion of the media. So we all know about predisposing factors: hypertension, Marfan's, Turner's, Ehlers-Danlos. All of those are predisposing factors for dissection. Now, there's a classification of intimal tears put out by Svensson. So the type 1 is a classic dissection with an intimal tear, so we're all kind of used to those, seeing those. Intramural hematoma is a type 2. With an intramural hematoma, the thinking is that even if we may not see the defect in the intima, that most of these occur because of a small defect in the intima, a small intimal tear. Then you can have an intimal tear without a hematoma. Those are the so-called flapless acute aortic dissection. These are very hard to see on a CT scan, but they can see those intraoperatively, see the intimal tear intraoperatively. And we can have a penetrating aortic ulcer, and then we can have the type 5 is an iatrogenic or traumatic dissection. So those are these are the classifications of intimal tears by Svensson. So when we talk about aortic dissections, we can classify them as acute or chronic. The acute dissections, less than 2 weeks old, chronic dissections, greater than 2 weeks old. 75% of deaths with dissection occur in the first 2 weeks. So that is important in terms of prognosis. Classification, the Stanford type A, dissection involves the ascending aorta, it's a type A, and these require surgery to prevent complications, and these are complications that can cause instant death. And that's why they require the surgeon to address them immediately. If there's extension of dissection into the pericardium, you can have tamponade. If there's extension to the aortic valve, you can have aortic valve regurgitation, extension to the coronary arteries. That can also result in myocardial infarction. So all these complications can result in instant death. So that's why these type A dissections need to be dealt with immediately. The type B, distal to the left subclavian artery, involving the descending aorta, these tend to be treated medically. Then there's a DeBakey classification, type 1 entire aorta, type 2 ascending aorta, type 3 if it involves the descending aorta. So with the DeBakey classification, type 1 involves ascending and descending, type 2 just the ascending, type 3 just the descending, and you can divide it into 3A and 3B depending on the extension. So the Stanford is the easiest to deal with, where you just think about the ascending aorta. Any dissection that involves the ascending aorta then would be classified as a type A using the Stanford classification. Now, when we evaluate dissections on CT, and then we, in our report, what are the things that we want to talk about? Well, you want to describe the type of dissection. Is it a type A or a type B? The entry tear location, which is important, and we'll talk about that in a minute. The extent of the dissection. Where does the dissection begin? Where does it end? Great vessel involvement. Does the flap extend into the great vessels off of the top of the aorta or into branch vessels? And then the abdominal aorta branches, which originate from the true lumen, which originate from the false lumen. Is there any extension of dissection into branch vessels of the abdominal aorta? The size of the false lumen, is the false lumen significantly compressing the true lumen? That can result in perfusion abnormalities, especially within the abdomen to the bowel. Fenestrations, are there any other openings within the dissection flap except the entry tear? Because additional fenestrations tend to maintain patency of the false lumen. And then complications, is there pericardial fusion? Are there any problems with renal perfusion? So these are the things you want to think about, so you create a kind of a checklist in your mind of these things to go through when you're dictating a report on an aortic dissection. We also want to take measurements. So we want to measure the aortic annulus. So that's down here where the valve is. And these measurements in red are measurements that you should take on coronal views because of the course of the aorta. See, it's going to be harder to take these on the axial views. It will artifactually kind of enlarge the measurement. So you don't want to take these particular measurements on axial views. Coronal views or sagittal views sometimes are best for these measurements. For the aortic annulus, sinus of Valsalva, and the ascending aorta, coronal views are best for those measurements. These other measurements you can take on your axial views, the measurement of the arch, the descending aorta, abdominal aorta, and you want to look for the maximum diameter, including the true and false lumen. So you want to include those measurements in your report when you're describing a dissection. So when we're going through this, so these measurements are measurements that you can take on the axial views. These measurements you don't want to take on the axial views. Coronal views might need sagittal views in some cases, but coronal views are usually best for these guys. Okay. So we talked about the classification. Now your classic type B dissection, the flap kind of starts just distal to the left subclavian artery. And in this case, you can see that many times the entry tear is located distal to that. We can identify the entry tear now in many of these cases because our CT scanners are fast enough, even without cardiac gating, to be able to define the entry tear. But what tends to happen here is even if the entry tear is located distally, the dissection propagates forward and backwards. And of course, it could propagate forwards as far as it wants. But when it propagates backwards, these tend to stop right at the takeoff of the left subclavian artery. And that's why you get this classic appearance for these type B dissections. Even though the entry tear is located more distal, that proximal propagation stops at the origin of the subclavian artery. Okay? So it's a classic appearance of a type B dissection. Now, you guys over here, if I show you this case, what type of dissection is this? Is this a type A or a type B? Well, where does the dissection go? It does go right. So what part of the aorta is this? Yeah, so this is the arch. Does it involve the ascending aorta? No. So this does not involve the ascending aorta, but it does involve the arch. So that's the question then. So a dissection that involves the arch, is this a type A or a type B? And this would be a answer? No. This would be a type B. So this is not treated surgically. So remember in that Stanford classification, they described the type B as distal to the left subclavian, and then the type A is, but nobody talks about the arch, right, in those classifications. So what happens when a dissection is involving the arch? Well, this is a type B with arch involvement. So these are classified as type B. These are treated medically. So if you have a dissection that extends to the aortic arch but not to the ascending aorta, then this dissection can be treated medically, so that is treated as a type B type of dissection, just to clear that up. Okay, so that can be confusing. All right, what about this case? What kind of dissection is this? So we say this is an A because what?
Involves the ascending aorta.
Yeah, so this dissection does go to the ascending aorta, right? Do you see where the entry tear is? You see it on the sagittal view? Yeah, so here's the entry tear over here. So would this be treated medically or surgically? Or what treatment do you think this patient should get? Why? See, so in the old days, we would have said, okay, that's a type A dissection and it extends to the ascending aorta, so this should be treated surgically. But the point of identifying the tear, the entry tear, is very important for these types of cases. All right? So no question that the dissection does extend to the ascending aorta, but the entry tear here is in the descending aorta. Okay? And so there is now this new classification of aortic dissections, which is put out by the by the Vascular Society and the Society of Thoracic Surgeons. And here it becomes important to identify the entry tear. So you don't have to memorize these numbers, but the aorta is divided into these different sections of the aorta. So the zero, that location is the ascending aorta, and then you have the aortic arch over here, and then going down the descending aorta. So the way they will classify a dissection is to say where the entry tear is and the extent of the dissection. So in this case, if the entry tear is located in the ascending aorta but extends all the way down to this ninth location here, this would be a type A9. But what if the entry tear is in the descending aorta, as in this case, but it extends to the ascending aorta? Well, then it's classified by the location of the entry tear, type B, and then these subscripts here tell you the proximal extent and the distal extent. So something like this, where the entry tear is in the descending aorta, but it goes to the ascending aorta and keeps going down to the descending aorta. So this would be classified as a type B subscript 0 to 9. And the reason for that is the treatment that the patient would receive. Because for the treatment here, if they're able to close the entry tear, then the patient would not require surgery on the ascending aorta. And so this patient, the patient that I showed you, was treated with an endograft. And so the idea of the endograft is to close the entry tear, and here's what happens. So after stenting, you can see, so here's the stent. After the stenting, you can see what happens here to the ascending aorta. It gets smaller, and then 3 months later, it's completely healed. So this patient then did not require a sternotomy to actually go in there, repair the ascending, and put in a graft into the ascending aorta, which is probably what would have been done in the past. By identifying the entry tear and by closing the entry tear, they will allow the ascending aorta then to heal. And so this is now this new classification of dissection. So identifying the location of the entry tear is very important in these cases because it determines the management. Okay? So in this case, what will we say here? What kind of dissection is this?
Stanford A.
This is an A, and do you see where the entry tear is? Let's go through it again. It goes down pretty far. You can see it actually extends into the branch vessels there.
Oh, ascending aorta.
Yeah, so here you could see the entry tears in the ascending aorta. So this patient would require surgery, right? So this patient would require surgery for treatment, okay? So this tear is in the ascending aorta, and you can see it's an extensive dissection. It actually goes down into the SMA. Is there another finding there on the last image that's illustrated?
Left kidney.
Yeah, so what's happening here in the left kidney, you can see that it's not enhancing as much of the right. The renal artery is coming off the false lumen, which is typical as these dissections extend down. It's typical for the false lumen to kind of spiral off to the left side. So the left renal artery often comes off of the false lumen. So you can see these perfusion abnormalities within the left kidney. So this is something also for you to look for when you're reading the dissection cases, is for perfusion abnormalities within the kidneys. Okay, so that's our discussion of these types of. I is indeterminate, right? If you can't tell where the entry tear is, then it's an indeterminate dissection in terms of the classification. So on chest x-ray, if there's any acute enlargement of the aorta, that's where, of course, you would need to compare with prior films. Displaced intimal calcifications, very unreliable, but you can see the number on chest x-ray has got to be displaced by more than a centimeter before you can say it's displaced. But that is an extremely unreliable sign to make the diagnosis. So of course, we're going to do it by CT. We'll make the diagnosis by CT. We saw this case where even on a non-contrast CT sometimes, you can still see the displaced calcification in the intimal flap. Okay. In this particular case, what can we say about the dissection? Yeah, well, it's going down to the ascending aorta. I haven't shown you the entry tear, so we don't see that. It is involving the ascending aorta. Any other problems?
It extends into the left subclavian.
Yeah, it extends into the left subclavian artery. Is it extending into the brachiocephalic? Maybe. Hard to tell there. What about the kidneys?
The right kidney.
Yeah, the right kidney, you can see that the attenuation of the right kidney is reduced compared to the left. So these are all important observations that you want to make when you're interpreting the CT scan. All right, so this is an obvious case of hemopericardium, right? So this is ruptured, right? So this dissection is ruptured. You see all this blood in the mediastinum coming down around, and then we have a hemopericardium there, and you can see that it's actually extending down. That hematoma extends down the descending thoracic aorta and can extend down into the abdominal aorta too. Okay, so ruptured type B dissection. Here you have the on non-contrast the high attenuation hematoma actually extending here into the pleural space. So this is a rupture in this particular case of that dissection. So this patient has chest pain, and we can see the dissection there, okay? So what type is this? E. And then when we look at the false lumen and the true lumen in this particular case, what do we notice?
They're equally opacified.
They're equally opacified. Is there anything else? What about the relative size?
False is bigger.
Yeah, the false is much larger than the true lumen here. And then when I look at the branch vessels here coming off the true lumen, in this case in the abdomen, what complication might this patient have?
Bowel ischemia, mesenteric.
Yeah, and what do we call that? There's a term for that, and that's malperfusion syndrome. Okay, so when you have a dissection that results in decreased perfusion, especially of these vessels here going to the bowel in the abdomen, because the true lumen is being compressed by the false lumen, then that can result in ischemia, in bowel ischemia. And the treatment for that would be what? Yeah. So the treatment for that would be a stent to maintain the patency and the flow through the true lumen. Okay. So here's a post-stenting. And the other thing that can happen is when you do that is it can promote thrombosis of the false lumen. Okay. Interestingly, if you have vessels that are only being perfused by the false lumen and you have malperfusion, what would you do? What might they do for that? Remember now, the vessels are coming off the false lumen, but there's decreased blood flow going through those vessels.
Fenestration.
Fenestrations, right. So there they would actually put holes in the dissection flap to allow the blood flow to get through the false lumen into those branch vessels that are coming off the false lumen. Okay. So here when we look down lower, look what happens to the dissection flap and what is it doing here? What's happening here? Well, what vessel is this over here? So that's the common iliac. So the dissection flap is doing what? Not just extending, but it's actually obstructing, right? So you see how the dissection flap here is coming down and actually obstructing the right common iliac artery, okay? So here it is, there it is, and you can see how there can be some obstruction there of the iliac artery. And here it is on this coronal reformatted view. Look at that, right? See what's happening there. So this is called, you can have static and dynamic obstruction of the true lumen by the false lumen. So static obstruction is if the dissection actually extends into a branch vessel like that, and you can see how it can narrow the vessel and then result in obstruction. But dynamic obstruction, especially during systole, is when the false lumen enlarges and compresses, actually more in diastole, because the false lumen tends to fill after the true lumen. So when the false lumen dilates there, it can compress the true lumen to the point where it actually starts to obstruct the branch vessels coming off of the true lumen. And you can also have a combination of static and dynamic obstruction if the dissection extends into that branch vessel. So this can also be a problem where with progressive enlargement of the false lumen, where it tends to push the dissection flap over to the point where it can obstruct the branch vessel. And that's called dynamic obstruction. Okay. So here's an unusual appearance of a dissection. So you see that dissection flap up there. And what's happening here is that the dissection actually was from the ascending aorta, and as it peeled off during systole, it's being pushed into the aortic arch. That's what you're seeing here. And you get this funny view. See that? Where it looks like there's a tunnel here right in the aortic arch. That's this guy over here. Okay? And so a complication of this kind of unusual thing here, is that it can obstruct the great vessels coming off of the arch. So the tear has been down here, and then that flap has been torn off, and during systole is actually being pushed out into the aortic arch. Here's another unusual appearance. So here's a dissection again of the ascending aorta, and this guy down here is the aortic valve. This patient had aortic valvular regurgitation as a complication of the dissection. And what was happening here is that here's the dissection, and it's being pushed during diastole. It's being pushed down into the aortic valve. Here's the aortic valve. You can see it's pushed down into the aortic valve and keeping the aortic valve from closing, resulting in regurgitation, aortic valve regurgitation. So another unusual thing that we can see with dissection. Okay. So that's diagrammed here. So this tear in the ascending aorta, during systole it's pushed forward, but during diastole it's pushed backward down into the aortic valve. Okay, what is unusual about this dissection? You can look at this image because it's nicely illustrated here too. See anything funny looking? Well, there's a tear. You can see the tear here. What is this guy?
What's the vessel coming out?
What is that guy? See it? Well, it's not the patient doesn't have a PDA, but that's the location, right? So what is this? Yeah, so this is actually extending into that ligamentum arteriosum or a ductus diverticulum, right? You can have a ductus diverticulum there. And in this case, because of the orientation of the dissection, it's coming off the false lumen, right? Can that be a problem? Presentation 1 month later. What's happened? Three years later, it's ruptured, right? So here, where you have this coming off the false lumen, you can get progressive enlargement. It's going to be an area of weakness there within the false lumen, right? Because of that ductus diverticulum, and then now, over time, it's actually ruptured. And you can see how the hematoma is coming down now and actually going around the pulmonary arteries. So that thing ruptured. So that's another important thing that you want to note if you have that, if you notice that in your dissection. If we suspect dissection of the ascending aorta, well, what's the best study to do? Yeah, cardiac gated CT, because there's a lot of motion in the ascending aorta, and to identify the dissection flap, you'd be better off doing a cardiac gated CT. Now, we talked about the complications of dissection of the ascending aorta, the three that result in instant death, right? Those are the complications. So when it's not gated, you have a lot of motion artifact. When it is gated, then you don't have as much motion artifact. So at some places, the routine protocol for a dissection is a gated CT scan, just because if the dissection happens about the ascending aorta, you'll get motion-free images. So that's what the flap looks like when you're not gated. When it's gated, you can see the flap and the entry tear, and all those things are much better demonstrated. Okay. So here again, sometimes even with the gating, you may have to change your reconstruction windows to be able to look at the ascending aorta without the motion artifact. So you will have that option if you cardiac gate the study. Which coronary artery is most likely to be involved with dissection of the ascending aorta? If it extends down to the coronary artery? The answer is right coronary artery. Dissection flaps, for whatever reason, tends to extend down closer to the right coronary artery. So the right coronary artery is more likely to be involved with dissection than the left coronary artery. MRI, these can be very complicated because of slow flow and artifacts within the false lumen. So CT, of course, is the way to go when you're trying to make a diagnosis of aortic dissection. So there's CT, MR with contrast showing you the dissection flat. Okay. All right, so we'll stop here and we need to go on to the quiz.